So let's talk about uh, the next set of drugs. They're called DMARDs. And for some reason I cannot spell. It's actually, there's a D here, and then there's an S. It's DMARDs. How do I get this name? Disease, so D comes from here, modifying M, anti-rheumatic AR, drugs DS. DMARDS, DMARDs, drug modifying anti-rheumatic drugs. Okay, so again, there's different varieties. For the sake of simplicity, I've boiled it down to, I've done a review, and based on what I've looked at in the literature, I boiled it down to three subcategories or three categories. The first one is biologics. The second one is non-biologics-major, and the third one is non-biologic-minor. Now, biologics have two subcategories: monoclonal antibodies and soluble receptor antagonists. The non-biologic majors, we have methotrexate, which is a cytotoxic, and sulfasalazine, which is anti-inflammatory. You have two infectious disease drugs, which are going to be covered in infectious disease pharmacology, which is an anti-malarial drug, hydroxychloroquine, and tetracycline, which is minocycline. So I'll cover it in those lectures. Okay. And then with non-biologics minors, we have the gold salt, we have penicillamine, and then I have the transplant drugs or the cytotoxic drugs that I've categorized within the cytotoxic category, which is azothioprine, cyclosporin, tacrolimus, and sirolimus. Okay, so that's how we've broken it up. That's how I've broken it up. I think it helps with learning these drugs well. And so let's get started. The first thing we're going to talk about are the biologic DMARDs. Okay, so there's two categories. So there's a monoclonal antibody and there's a soluble receptor antagonist. So first thing, there's some inherent difficulty with studying these drugs. Why is that? So you know how with drugs we look at, okay, this is my prototype, and these are the other drugs in this category. Okay. Here we don't have any prototype. Well, why is that? Well, these drugs are dependent on what receptor they target or what cytokine they target. So in other words, if a drug targets receptor 1 for disease 1, a drug may target receptor 2 for disease 2. Drugs for receptor 3 targets for disease 3. So in other words, they all have different receptors they target, they all have different side effects, they all have everything different. So it's very difficult for me to create one prototype drug which will help me learn most of the information about all the drugs. So that's where it's different. And that's where these drugs are different. So we'll start with monoclonal antibodies. So these are the MAB drugs with MAB at their end. Okay, rituximab. MAB, it's a monoclonal antibody. What's the concept? So antibodies, and again, this goes back to immunology, anatomy, and physiology. They can bind on what? They can bind on the receptors of the bad people, bad things. For example, if I've got breast cancer and it's got a little HER2 receptor, well, I can have a HER2 antibody that binds to this. And when it does, it increases the immune response and takes out the cancer. Okay? Or I can have rituximab, okay, or infliximab. Infliximab is a monoclonal antibody against tumor necrosis factor alpha, which inflicts damage. Infliximab inflicts damage. Makes sense. And because it targets TNF alpha, it destroys big chunk of TNF alpha, which decreases inflammation. So these drugs can decrease inflammation or increase inflammation. Their mechanism of action, what they do, and side effects depends on the receptors that they bind to and which target cell do they target. And that's the way to study these drugs. For example, if I have to study infliximab, well, what is it? It's a monoclonal antibody against TNF alpha. So I need to know what TNF alpha is. It's a pro-inflammatory mediator, cytokine. Well, it's going to attach to TNF alpha and it's going to take it out. It's going to decrease inflammation. Aha! Let's say trastuzumab. What does that do? It's a monoclonal antibody against breast cancer, a specific type of breast cancer with a specific kind of receptor on it, HER2 receptor. Okay, so breast cancer, HER2 receptor, they give them antibody, boom, takes out that breast cancer cell. Similarly, I can actually study all of them. Again, I think it depends on what are covered clinically in your coursework, and for your practice, what are the ones that are important. If you're in the transplant unit, you may have certain monoclonal antibodies that may be more important than if you're in the GI clinic taking care of patients with inflammatory bowel disease. You may have a different monoclonal antibodies that you might want to study up on. But again, I've given you the concept of how to slay these drugs and be able to understand what these drugs are all about. Side effects are individualized, some of the common ones. Injection site irritation, so again, monitoring of the site. If the drug decreases the immune response, then watch out for infections, right? And cancers. Big one that's asked is TB testing. And we test for tuberculosis prior to starting therapy, initiating therapy, so that if we decrease immune response, we may reactivate the tuberculosis that's lying in dormant. The providers may choose to treat them for latent TB before starting these therapies. Okay, so just sometimes a fun question to ask. Okay. If I'm decreasing their immune system and now I'm also giving them corticosteroids, what am I doing? Corticosteroids plus, let's say, infliximab, which decreases inflammation. Aha! That will lower their immunity. Okay. Again, we are changing the soldiers of immunity, so monitor labs which monitor their blood count, which is WBCs or white blood cells. Okay. And then again, monitor for signs and symptoms of infection. So that's a big one. But again, these are some of the overarching side effects. But like I said, specific side effects are specific to the drug. The other one is the CEPT drugs or the CEPT drugs, soluble receptor antagonists. And how do I remember them? So you see the receptor CEPT, CEPT. So remember monoclonal antibodies MAB, antibody AB, and MAB. CEPT drugs are CEPT. They target the receptors. Okay? And what it is, the concept is simple. You have cytokines that actually are chemicals that recruit soldiers to fight. These drugs attach to the cytokines and they prevent cytokines from acting. These are the CEP drugs, and again, several. So, you may have these drugs and they have their own side effects depending on the cytokine that they target. Okay. All right, let's talk about the next one, which is methotrexate. Now, this is a non-biologics. Remember, we finished the biologics, which is monoclonal antibody, and the sept, which is the receptor antagonist, soluble receptor antagonist, biologic drug. So now the DMARDs, we're going to go into non-biologic, and we have the major and the minor. So we start with methotrexate, which is a major non-biologic DMARD, and it's a cytotoxic one because it's toxic to the cell. How is it toxic to the cell? It binds to folate, which means the less folate is available to body cells, which means it's toxic to the cells. What is it used for? Rheumatoid arthritis and psoriasis. Again, autoimmune diseases, immunity, which is, kind of overactive, and we're going to decrease the immunity. How do I know it's working? Well, the signs and symptoms of inflammation are going to go down. So, in other words, if I have joint pain, joint inflammation, you're going to see those going down. And when you monitor disease or pathology, you're going to see the severity of the disease has gone down. So if it's rheumatoid arthritis, you're going to see the disease now progressing better in the patient. The psoriasis symptoms are going to become less. So again, that's how you know the medication is working for that particular disease. Side effects. So again, injury to liver and kidney and lung and bone marrow. 3, 4. So liver, lung, kidney, bone marrow. Kidney, monitor eyes, nose, intakes and output, and bun and creatinine. Okay. Lung toxicity, you're going to see lung injury. This is kind of unique to the drug. So again, shortness of breath, abnormal lung sounds. Hepatotoxicity, observe lung, liver function tests and liver symptoms. And then with bone marrow suppression, if the white blood cells are suppressed, they may have increased infection. If platelets are suppressed, increased bleeding. If there's anemia, that's also an issue because the RBCs are less. So remember, the kidneys are negatively impacted, which means erythropoietin is not getting produced, and then the bone marrow is also affected. So it's a double whammy when it comes to suppression of red blood cells. Again, GI ulcers. A note: pregnancy. Don't give this drug. Why? Remember folic acid you give to mothers so that they don't have neural tube defect. This drug prevents folic acid from being available to the cells. So it's going to cause a lot of issues when it comes to fetuses. Okay? So that covers methotrexate. So let's talk about, so hydroxychloroquine and tetracycline, minocycline, we're going to cover in infectious disease pharmacology. So we're going to talk about the anti-inflammatory non-biologic-major DMARD, which is sulfasalazine. So let's take a peek at that. Okay, so that's sulfasalazine. So how does that work? So sulfasalazine goes in the GI tract. Okay, and it gets converted to 5-amino salicylic acid. So remember salicylic acid? So that's aspirin, right? So essentially, what it does is, so remember aspirin does what? It's a COX inhibitor, right? So remember cell wall, arachidonic acid, and then it goes into either COX or LOX pathway and produces prostaglandins or leukotrienes, which cause inflammation. Well, 5-ASA inhibits COX and LOX, which inhibits prostaglandin and leukotriene formation, which inhibits inflammation. Aha, that's how it's acting locally at the site of inflammation to decrease inflammation. Easy, right? What is it used for? Rheumatoid arthritis and inflammatory bowel disease. We're going to talk about Crohn's disease and ulcerative colitis. So it's used a lot for that purpose, and of course for rheumatoid arthritis as well. How do I know it's working? Decreased inflammation and the disease process. So if it's bloody diarrhea, it may get better. If it's joint pain and joint swelling, it may get better. Some of the side effects, again, nausea, vomiting, diarrhea, abdominal pain. So again, with that, if we give enteric coated drug and divide it into doses, it actually gets past the stomach and helps us manage especially the nausea and vomiting part. There's hepatic or liver issues. So again, we monitor the livers in labs. Uh, Bone marrow suppression. So again, folic acid goes down. Folic acid is one of the drugs, one of the things that are used for RBC production. So they have megaloblastic anemia, anemia in which the RBC is the bigger size. And again, WBCs also go down. So again, monitoring for that. And then again, Uh, sperm. There's a rare side effect. The sperm count goes down while the patient is taking these medications. However, it returns back to normal after discontinuation. Okay, so that's just something interesting to know, especially when it comes to males taking these medications. Okay? Now, we've talked about non-biologic majors, right? So now let's talk about the non-biologic DMARDs that are minor. So we start with gold. So oro thioglucose. So oro, remember the when you look at the periodic table, this is the symbol for gold. So oro thioglucose. Okay. Again, this drug is being used much less than it was before because we actually have better treatments now. Uh, Again, it's used to treat rheumatoid arthritis, inflammation. It's going to decrease inflammation, and the disease severity and course is going to become better. Uh, so again, kidney, liver, and red blood cells damages all of them. We got to do the same thing we talked about before with other drugs, which is monitor, and then if we start to see those symptoms, we got to call the doc, we'll call the provider. And again, with toxicity, that's something else. There's itching and rash, and if you see that, then contact the provider as well. The non-biologics. Non-biologic-minor, the next drug is penicillamine. It's a byproduct of penicillin. What is it used for? This is a medication which is actually used for chelation of heavy metals. So there are drugs where there's diseases where there's heavy metal that accumulates in the body, like Wilson's disease. So we use this drug to chelate and get rid of extra heavy metals in the body. It is used for kidney stones, especially cystine kidney stones, and then it's used for rheumatoid arthritis. So how does it work? Well, let's say you have a heavy metal like copper in Wilson's disease. Okay, penicillamine attaches to it and makes it soluble enough to get excreted in urine. Same with cystine. You got a lot of cystine, it's giving you kidney stones. Well, penicillamine attaches to it, gets it excreted in the kidneys. Again, also it works through a mechanism of action by decreasing T cell activity, and it helps with rheumatoid arthritis. So again, it helps with heavy metals, kidney stones, and rheumatoid arthritis. So is it working? Well, with heavy metals, whatever that disease is and whatever that metal is, you're going to see less symptoms of toxicity, and the patient's going to get clinically better. With kidney stones, again, they're going to have less incidences of stones and nephrolithiasis, right? And then rheumatoid arthritis, you're going to see decreased inflammation, and then the disease is going to be less severe and is going to have a better course. What are some of the side effects? So again, there's hepatotoxicity and bone marrow toxicity. Okay. One may experience allergic reaction, which is rash. 33% of the patients have it, and we need to contact the provider when they see that. With toxicity, we see fever, sore throat, chills, and bleeding, and again, we stop and contact the provider. So the uh, next category that we're going to talk about, which would be the last set of medications within DMARDs, are going to be the non-biologic minor DMARDs which are cytotoxic in nature, and these are generally used for transplant. So again, these are very powerful medications, and within them you see there's cyclosporin, there's tacrolimus, there's sirolimus, and then there's azothioprine. Okay. Now, the mechanism of action for these three drugs, which is cyclosporin, tacrolimus, and sirolimus, is actually very similar. So let's talk about these first, okay? So remember, this goes back to the anatomy physiology of the immune system, which specifically refers to the humoral immunity. So remember, we have the antigen presenting cell, which is right here, and it's presenting the antigen, right? And it has a CD4 receptor, and then again it's presenting the antigen. And then you have T helper cell, which has a T cell receptor that attaches to the antigen and a major histocompatibility complex 2, which attaches to CD4, right? So this attachment happens and the co-stimulatory attachment happens. And then what happens? The T helper cell produces interleukin 2, which then stimulates itself to produce interleukin 4 and 5, right? So interleukin 4, what does that do? It proliferates more B and T cells, the same kind that were involved in this interaction, right? And then interleukin 5, what does that do? It gets the B cells now to differentiate into plasma cells, which gives me antibodies. So I get more B cells, T cells, and antibodies specific to that particular antigen. Okay. So what if cyclosporin, a medication, it acts within the T helper cell and prevents release of interleukin 2? It does that. And there's a mechanism which is, again, it's got lots of receptors and pathway, but I'll just keep it simple, where it just acts within the pathway in the T helper cell to prevent release of interleukin 2. Tacrolimus also is very similar. It also acts on the T helper cells and prevents interleukin 2 from getting produced. And because interleukin 2 is not produced, interleukin 4 and 5 are not produced, and you don't have the immune response that happens. Now, cyclosporin and tacrolimus actually attack the same pathway, but they attack it at different points to prevent the IL-2 from getting released. Sirolimus is actually more interesting. What it does is, the T helper cell is able to produce interleukin 2, but you know how that interleukin 2 that's produced has to stimulate the T helper cell that produced it to then produce interleukin 4 and 5. Well, sirolimus prevents that interleukin 2 that has been produced to not stimulate self and not produce interleukin 4 and 5. So in all three cases, interleukin 4 and 5 are not produced, right? But in the first two cases, it's the interleukin 2 that's not produced. In the third case, which is sirolimus, interleukin 2 is produced, but is not allowed to self-stimulate the T helper cell to produce IL-4 and IL-5, which again helps with the immunity. And how does it do that? It decreases immunity by decreasing proliferation of B and T cells and preventing differentiation of B cells into plasma cells into antibodies. Okay, so that's how these three drugs work. Let's take a look at their side effects. Now, something is very common between all three of them. You know what it is? All three of them are going to decrease your immunity, and when they do, they're going to increase your risk for infection and increase your risk for malignancies or cancer. Because remember, your immune system helps you fight those two things, right? So that makes perfect sense, right? What is cyclosporin used for? Transplant. So if somebody gets kidney transplant, liver transplant, rheumatoid arthritis, psoriasis, Lupus, that's an autoimmune disease, just like rheumatoid arthritis, inflammatory bowel disease. How do you know it's working? Decrease inflammation, decrease immunity. If it's transplant, no rejection. If it's rheumatoid arthritis, different markers, right? If it's IBD, ulcerative colitis, you're not going to see bloody diarrhea. Okay, lots of side effects. Liver, kidney, both are, it's toxic to both. Uh, um, Hypertension, so monitor blood pressure, hypersensitivity, hirsutism, which is you get lots of hair growth. Again, it's reversible after the drug is discontinued. One of the questions that come up is, can I discontinue this drug? So the question is the pathology lifelong? So if somebody's going to be keeping the transplanted kidney lifelong, then they might need to be on the drug lifelong. However, if you're giving it for psoriasis and that gets better, and then there's a chance that we may discontinue the drug. So again, these are some of the things when it comes to liver and kidney. Again, monitor. Uh, Hirsutism is more educational. Hypersensitivity, if they start to develop rash, again, with medications, anaphylaxis, things like that, we've got to contact the provider. And again, keep an eye on the blood pressure. If it gets high, we refer to the providers. So that's cyclosporin. Tacrolimus is used for transplants and rheumatoid arthritis. So again, is it working? If the organ is not being rejected, hey, we're doing well. Lesser side effects. So again, it's nephrotoxic, but not as hepatotoxic. So if somebody's liver is shot, this might be a good option to cyclosporin. Again, infection and cancer, we've covered it, but it's got some other interesting side effects. There's neurotoxicity, so headache, insomnia, pain, fever, tremors, and weakness. Diabetes is one of the big ones. So, and then also diarrhea, abdominal pain, and nausea. So these are some of the big side effects, important side effects with this drug. Okay. Sirolimus, again, we use it for transplant. Side effects, again, it's damaging to the kidney, and then also neurotoxic with headache, pain, and insomnia. Um, Cholesterol, so that's one of the interesting ones which separates it from the other drugs. So like we have diabetes for tacrolimus, we have increased cholesterol for sirolimus, okay? And then of course diarrhea, abdominal pain, nausea. So for cholesterol, we usually test before prescription and regularly while the patient is on this drug. The last drug which we didn't talk about was azathioprine. So its mechanism of action is different from the other three, completely different. And the way to remember it is you see the prine at the end. So prine rhymes with purine. So that's what this does, is azathioprine becomes 6-mercaptopurine. And that decreases the purine. So remember when we talked about uric acid, we talked about how purines are important in cell DNA, and how cell DNA, when it gets damaged, releases purines, which get converted into uric acid by xanthine oxidase, right? Anyways, if you're not sure, make sure you review that video. But purines are very, very important for DNA production. So essentially, when you give this drug, you have less purines that are available. Essentially, that acts as poison for lymphocytes and causes cell death. Okay, and apoptosis of these cells. Okay. So again, these are great drugs. This is a great drug. It can be used for transplant because again, you have less lymphocytes, less immune response. You have rheumatoid arthritis and IBD. So it actually helps with that as well. Leukemia, again, is azathioprine. It's going to prevent the DNA from replicating in the cancer cells very quickly, right? So there's some interesting side effects. So remember, infection and malignancy are true for all of these. So it's true for this one as well. The one malignancy it predisposes you to is because it affects lymphocytes. There's a higher tendency to get lymphomas. It's like a poison for the lymphocytes. So this poison may cause lymphoma. Now, are there things that may aggravate or magnify this particular side effect? And the answer is yes. If somebody have Epstein-Barr virus infection, so EBV or Epstein-Barr virus is like HPV for the genitals and the head and neck. So you know how this virus irritates and causes genital cancer and head and neck cancer? Epstein-Barr virus does the same thing for lymphoma and bone marrow and hematological system. So if I already am taking azathioprine and I have Epstein-Barr virus, that magnifies chances of getting hematological cancer, especially lymphoma. Again, it suppresses the bone marrow. I think we've talked about how it's a poison for lymphocytes. What are you going to do? Well, remember monitoring for infections, monitoring CBCs, platelets, WBCs, right? Hepatotoxic, what are you going to do? Monitor liver and liver labs, okay? Again, nausea, vomiting, diarrhea, fever, and rash, what are you going to do? That's another thing to watch out for. Report those, okay? So let's do a quick overview of DMARDS and how we broke it up. So we started with biologics, which is monoclonal antibodies and soluble receptor block antagonists. So that's the MAB drugs, right? MAB, and the receptor, CEPT drugs. There's no easy way to learn this, but it depends on the receptor that they're targeting and the target cell. And that will tell you what they're trying to stop. Is it cancer cell they're killing, or is it your own immune system that's gotten out of whack that it's trying to slow down? Okay, so that's biologics. Uh, and I've shared with you a way of how to study them. With non-biologic majors, we have methotrexate, which is cytotoxic. Again, we're going to cover the antimalarial and the tetracycline infectious disease. And then we have sulfasalazine. So again, we talked about uh, methotrexate and how it's used to decrease folic acid available to the cell, which decreases the immune response to the diseases because it's toxic to immune cells. So again, lots of side effects: liver, lung, kidney, bone marrow injury, and then again with pregnancy, watch out for that, and GI ulcers. The next drug was sulfasalazines like aspirin for the tummy, for the area where there's inflammation. So acts locally on the site of inflammation by interfering with COX and LOX pathways, decreasing inflammation. So again, bone marrow suppression, liver dysfunction, and nausea, vomiting, diarrhea, and then sperm count goes down during the therapy. Uh, and that covered the non-biologic majors. With non-biologic minors, we start with oro thioglucose, all oro, right? And that's the gold salt. Used much, much less because of increased toxicity, liver, kidney, and bone marrow toxicity. So again, we have better drugs now. Penicillamine, which is a chelating agent, and that's how it decreases the T cell reaction. So again, liver and bone marrow toxic, uh, and then maybe some rash and allergic reaction. It's a byproduct of penicillin. Uh, the transplant medications are the minor DMARDs that are cytotoxic, and there were four: cyclosporin, tacrolimus, and sirolimus. Now, with mechanism of action, we covered how these three are pretty similar with how they stop IL-4 and alpha production, whereas azothioprine actually prevents cell DNA from getting made and cell DNA from cells causing cells to die. So it's like a poison for lymphocytes. Is the way to think about it, by decreasing purine metabolism. So this was interesting in terms of malignancy, especially lymphoma. Again, there's bone marrow and hepatotoxicity. Uh, with these three drugs, again, cyclosporin, tacrolimus, and sirolimus, all of them cause an increase in infections, decrease immunity, and increase cancers. There's liver issues with cyclosporin. Kidney issues are there with all three, unfortunately. Neuro symptoms are there with tacrolimus and sirolimus with neurotoxicity. And then there's some interesting side effects. So cyclosporin has increased hair and then increased blood pressure. Um, Tacrolimus has more diabetes that you get to see with it, whereas sirolimus has got more cholesterol that you get to see with it. And then peripheral edema, and then also some increased blood pressure as well, and then anemia and joint pain that we may have probably skipped very quickly. But again, anemia, joint pain, and peripheral edema. So there's some interesting differences between the side effects for all three as well, which is a great place to learn because when it comes to testing, if I were to give you tacrolimus, and what would be the very high priority action, and it would, if it were to have diabetes or checking their blood sugar or monitoring for their sugar, that suddenly becomes an option that you that where tacrolimus is different from cyclosporins and sirolimus. So that's essentially the DMARD drugs.